Hello, friends. I'll be talking on this important topic, sedation in ICU. So it's a overview on sedation. It's an important topic for most of the ICU trainees. So I'll just give a sort of an overall view on this concept of sedation in ICU. So when you look at sedation in ICU, it is considered as a key quality marker. I'm sure every listener would have heard of this acronym, FASTAG, where S stands for sedation and A also is very important, analgesia. So this analgesia and sedation go hand in hand in the practice of sedation in ICU. So now, in fact, they call analgesia first sedation, which means analgesia has to be given more preference to sedation, and there should be a component of analgesia also in the whole sedation process. So that is what we understand. So, and it's an important quality marker. So any patient who is in ICU and more so who is on ventilator needs to be on adequate sedation to keep him comfortable and pain-free. So this should be the concept. And someone who is not on adequate sedation or analgesia, it is a breach in the quality indicator. So when you look at the goals of sedation, so we have various dimensions to it. So one is when we talk about sedation in general, we incorporate anxiety, pain, and delirium under the same ambit of the whole sedation. And there are multiple reasons which act as a trigger for these components. And there are multiple interventions that one needs to adopt to alleviate this whole anxiety, pain, and delirium. So there are multiple dimensions to this. And when we talk about sedation, there is a overplay. There is a complex interplay and overplay of any of these factors, anxiety, pain, delirium, all of which would need to be addressed with analgesia and sedation. So why do we need sedation? So someone who is intubated and ventilated, we need sedation to increase the tolerance of this patient for the tube that is sticking in his throat. And for that, you need bit of analgesia also. And sedation is needed to relieve anxiety because someone who is not able to talk when someone is on a ventilator with a ET tube sticking in them, so they need to be relieved of anxiety. And it also helps in controlling oxygen demand of the brain, especially in a neuro insult. If there is a neurological pathology of any sort or a traumatic brain injury, so adequate sedation is needed to reduce the ICP and to control the oxygen demands of the brain. And sedation would also be needed to perform various procedures in ICU. So be it a CVC insertion or be it certain administration or certain positioning of the patient. For all that, for any procedures that one would embark on doing in these patients, sedation is mandatorily needed. So this is the sort of a broad understanding as to why we need sedation. So there are a lot of myths associated with sedation. So we believe when a patient is in pain, so he may be very restless due to a lot of pain, and we believe that giving sedation would be the way to go. So, but the fact is the treatment of pain is with analgesics and not with sedation. So that is something which very important because any patient is restless in ICU, he may be restless because of a lot of pain, and giving midazolam or any sedation will not settle him. So that is something one needs to keep in mind. And patient may be very restless because of delirium. And when there is delirium, we don't administer sedatives like benzodiazepine because it may worsen the delirium. Rather, we should identify that the problem, underlying problem is delirium, and we have to treat the underlying cause and we have to treat the delirium. And delirium is treated not with sedatives or benzodiazepine, but with antipsychotic drugs. So that is also something listeners should bear in mind. And sedation is not an answer for delirium, especially sedation with benzodiazepine is not an answer because it can worsen the delirium. And another important aspect is a patient is very restless, giving muscle relaxants to settle him is very traumatizing for the patient. Rather, we should look at alleviating his pain with analgesics and sedation rather than giving administering muscle relaxant. Giving muscle relaxant without analgesia and sedation tantamounts to causing more harm and more suffering and more anxiety to the patient. So these are some of the myths that every listener should bear in mind. And another aspect of sedation is, okay, in our zeal and enthusiasm to sedate the patient, we should not really look at embarking on over sedation because over sedation also is something equally bad. So for that, we need to keep three C's in mind. So the adequate sedation is situation where patient is calm, is coherent, and his compos mentis, which means is able to understand whatever is being communicated to some extent, and he is comfortable and calm. So these three C's are something that you could keep as a ballpark, that patient is settled in reasonable way. And exceptions. So there are certain exceptions where patients may need deep sedation, especially in traumatic brain injury, or you are dealing with high ICPs. So we would want the patient to be in deep sedation to reduce, with the intent that we reduce the ICP. Or you may be dealing with a patient with ARDS who is on a very high ventilatory requirement with a patient ventilatory dysynchrony, or you're proning the patient. So these are certain situations where we may have to sedate the patients very deeply, because to minimize or alleviate or mitigate the dysynchrony that may be prevailing in these situations. So these are some of the situations where we do accept that deep sedation is something. Otherwise, barring some of these conditions, in most other conditions, sedation should just be enough to keep patient comfortable and pain-free. So, and it is very important when we talk about sedation to titrate the sedation to achieve appropriate levels, because every patient's sedative needs are very different, and it needs to be titrated to the patient's needs. So it's one formula wouldn't fit everyone. So one dosage of sedation would not fit everyone. So titration to patient's needs is what is most important. For that, we use certain scores called Richmond agitation sedation score. So this is reasonably accepted score. As you see, it is scored from 0 to +4 and 0 to -5. So 0 is what we aim for, because anything above that, patient is restless, agitated, very agitated, combative. And below 0, it will be drowsy, light sedation, moderate, deep sedation, and unarousable. So we ideally prefer to be 0 to -1, or so 0 to -1 would be reasonable in most cases. So ideally we want 0, where he's alert and he's calm and compass mental and coherent. So another important aspect when you're titrating, as I said, one dose does not fit everyone, because most intensive care patients would have underlying organ dysfunction. They could possibly have liver dysfunction or renal dysfunction, where many of these sedatives and analgesics we use may have a delayed elimination, and this would lead to cumulative accumulation of these drugs, which may prolong their sort of a duration of sedation, or prolong their length of stay in ICU or length of ventilation. So we have to be cognizant about the underlying dysfunction when we are titrating these sedatives and analgesics, and keeping this in mind about the underlying organ dysfunction. And we need to also keep drug pharmacokinetics in mind. So when we set a treatment goal, as I said, the whole purpose of sedation is to create anxiolysis and a little bit of hypnosis and amnesia to keep patient comfortable. And along with this, there should be analgesic component also. It is always analgesia first, sedation. So our whole focus should be to alleviate pain first with adequate analgesia, followed by sedation. So this is the concept that every listener or every trainee should bear in mind. And when we are using obviously sedation, there are a lot of adverse effects that come with sedation. Especially this applies in more so hemodynamically unstable patients. You need to be vary about the type of sedation you're using, about the dose of sedation. And the normal drugs that are used for sedation and analgesia is morphine and midazolam. So these have to be given as boluses followed by infusion. And always a bolus is needed because of the pharmacokinetic nature of at least the opioids, which I will show in the next slide. And the other drug that we tend to use is propofol. The bolus we give 10 to 20 milligram, and infusion is 0 to 4 milligram per kg per hour. So why boluses is important for opioids is because they have especially morphine and midazolam, they have a long half-life, and elimination half-life is 3 hours. So this is a very interesting graph. So when you are using morphine for a patient, so you should always give a bolus to take them to titrate them to the level which we desire, and then followed by infusion. So if you look at here, you see if you want to increase the infusion from 3 mg to 4.5 mg per hour, just by increasing the infusion to 3 to 4.5, you wouldn't achieve the serum level. So you have to give 2 into 2 bolus level to take it to 4.5 and then maintain at this infusion. And even from here, if you want to bring down the infusion to 1.5, just titrating it down to 1.5 will not immediately bring down to 1.5. You have to stop the infusion for 3 hours and then bring it down for it to be brought to that level. So that's why it's very important. We need to understand the pharmacokinetics and pharmacodynamics of these analgesics and sedation that we would be using. And the new steady state, it takes 5 half-lives or 15 hours. So what it means is, if you want to increase from 3 mg to 4.5 mg without the bolus, it takes much longer time to attain that sort of an infusion. And even if you want to reduce it without stopping the drug, it would take much longer time to come down to 1 point because of the half-life, because it takes 5 half-lives to get to a new steady state or 15 hours. And more so, what adds on to this problem is volume of distribution. I'm sure you can look at my video of drug dosing in critical care. In critically ill patients, the volume of distribution is very large, which means the half-life of the drug also increases. It almost doubles in these patients. That's why the action of these analgesics or sedations act for a much longer time in critically ill patients. And the total body clearance also is sort of half. So this is some of the things that total body concentration also is half. So these are some of the things that we need to bear in mind when we are using these opioids and analgesics. So when we talk about sedation in ICU, these are the three broad components one should keep in mind. So when we say sedation, it is not only sedatives, it has to be with analgesics and it has to be with hypnotics, because you may be dealing with a patient who has delirium, and for delirium, sedatives may be more harmful. So we need to recognize that patient possibly has delirium and possibly give him analgesia and maybe antipsychotics to settle him, and sedation may worsen. So this is something one needs to keep in mind. So the common sedatives that are used in ICU is midazolam, propofol, and dexmedetomidine. And for common analgesics that are used is morphine, fentanyl, and acetaminophen. And common hypnotics that are used are haloperidol, risperidone, and quetiapine. So these are the common drugs that we tend to use to address these issues in ICU when it comes to sedation. So another important aspect is, whenever a patient is initiated on sedation, there is a policy of daily sedation interruption policy that needs to be kept in mind. That is called as lightning. And daily sedation interruption is a quality indicator, it's a structure indicator. And every ICU should have a policy where the sedation is stopped. I'm sure most listeners would know that we would stop the sedation early in the morning when we are doing rounds to assess the conscious level of the patient and assess them for weaning and possible extubation. So that is called lightning. And it has shown that daily sedation interruption has shown to reduce the duration of mechanical ventilation. And this is something that needs to be adopted in every ICU. And sedation interruption also reduces the complication rates as per these studies. And it is also shown to reduce the post-traumatic stress disorder. So it reduces the complications, it reduces the length of stay in ICU, or reduces the duration of mechanical ventilation, and reduces the risk of post-traumatic stress disorder. So lightning is something that needs to be adopted, and it is a quality indicator in every ICU. So that is something one needs to bear in mind. So this is about the backdrop of what we mean by sedation and what we mean by analgesics, what we mean by antipsychotics to alleviate the delirium. So this was a clinical practice guidelines that came in some time ago to look at the guidelines for management of pain, agitation, and delirium in adult patients. So in this, they have given levels of grading as we see. So the recommendation is the pain has to be monitored in all patients, and that gets grade 1B recommendation, which is a strong recommendation with a moderate level of evidence, which means every patient should be evaluated that if he's in any pain, and that needs to be addressed. And you have various pain scores, and the commonest ones many of you would be aware is the visual analog score. So some of these scales could be utilized to see and understand and to assess if patient is in pain, and that assessment of the pain is something that needs to be done. It's a strong recommendation. Or there is something called critical care pain observation tool is something that one could use. And the first line of treatment for pain in ICU is opioids, IV opioids. And this gets strong recommendation with some sort of an evidence that is prevailing. It's grade 1C recommendation. And non-opioid analgesics like acetaminophen or any other drugs that you would be using gets a weaker recommendation, grade 2 recommendation with some body of evidence. Grade 2C is what it gets. So our first line of sort of drugs for treating pain is with opioids in intensive care. That is something one needs to bear in mind. And as I said, the depth of sedation should be kept light, because as I said, it has to be at a 0. When you look at the RASS score, it has to be kept at 0, where it is calm, coherent, and compass mental. and that has shown to reduce the duration of mechanical ventilation, reduce the ICU length of stay. That gets a strong recommendation with a moderate level of evidence. And monitoring depth of sedation, as I showed you previously, can be done with the Richmond agitation sedation score or sedation agitation scale. So this is something which we could use, and this is a very simple tool. So we want something around 0 to -1 and not more than that. And the rating of sedation goes as light sedation, moderate sedation, and deep sedation. And you could rate it based on these scales or the scores that may be available. And the choice of sedation as per these guidelines is slowly moving from benzodiazepines to newer agents like dexmedetomidine or propofol, and that is grade 2B recommendation. So there is a preferential, there is a preference or there is a suggestion towards moving from benzodiazepine based sedation to dexmedetomidine and propofol in these guidelines. And the delirium, so the routine monitoring has to be done to ascertain if any of the patients are in delirium in all ICU patients, and that gets strong recommendation with a moderate level of evidence, which is grade 1B. And for delirium, you can use CAM ICU score or ICD score, which is a intensive care delirium sedation score. So this is something that one could use. And CAM ICU score gets a grade A recommendation. It has a good level of evidence to assess patients if they're having delirium. And one of the important risk factor for delirium in ICU has been confirmed to be the more usage of benzodiazepines. So that is something which has to be kept in mind when you're assessing patients. So if someone has been on benzodiazepine and is becoming restless, delirium is something that one needs to keep in mind. And sedation in delirium. So as I said, for delirium has to be treated with antipsychotics, which is risperidone, quetiapine, or haloperidol. If any sedation is needed in someone intubated, mechanically ventilated, dexmedetomidine is something that could be considered, and that gets grade 2B recommendation. So dexmedetomidine seems to be a good choice of drug for sedation. Also, there is a move from benzodiazepines to using dexmedetomidine for sedation, and it also helps in alleviating the delirium component. So what are the strategies for managing pain, agitation, and delirium to improve ICU? As I said, daily sedation interruption policy or the lightning, which I said is a quality indicator, is a strong recommendation. So every patient has to be given sedation-free period to assess, and he needs to be given sedation-free duration, which is called lightning, to reduce the length of stay, to reduce the complication, and to reduce the post-traumatic stress disorder. And as I said, analgesia first sedation is the way to go. Every patient in ICU has to be evaluated for the pain, and analgesics have to be on board first, and only after that sedation has to be considered, and that gets grade 2B recommendation. And there is a lot of emphasis in this guidelines on early mobilization of the patient, because even early mobilization of the patient from the bed to the chair and making him walk with support, all this has shown to reduce the incidence of delirium and reduce the duration of stay in ICU. So this is also very important. So there is a renewed emphasis on early mobilization in ICU. As you see the picture, someone is on ventilator is being walked, because the mobilization has clearly shown to reduce the risk of patients developing delirium. So this is something which we need to adopt more aggressively. And there should be some efforts taken to protect sleep cycle, that gets grade 1C recommendation, strong recommendation. So this was a Indian sort of a guideline that came. They did a Delphi sedation survey. As you see, Ramakrishnan was involved. So it was done from 2012 to January 2013. What they found was in this particular survey that the guidelines adherence had a very low compliance in our country, and benzodiazepine use was very rampant. 95% of all sedation in Indian ICU happened with benzodiazepine, and analgesia first sedation was non-existent in India. So which means to say, all the listeners here have to bear in mind. So our emphasis should be more on using analgesics followed by sedation to keep the patients comfortable. As per this survey, it was non-existent. And delirium was under-recognized. In less than 10% of the patients, the attempts were made to recognize this. This is also very important in India. We all need to be very sensitive about the patients having delirium, and they need to be assessed by CAM ICU score. That is also very important. And monitoring of sedation, analgesia, and delirium overall was found to be very low in this survey. And validated and recommended scales are rarely used, which means RASH score or visual analog score or CPOT score. So critical care pain assessment tool. So all these were rarely used, and even CAM ICU score. So that is something they have emphasized is something that should be utilized more. And early mobilization awareness also has been very low. So there should be effort to increase the awareness of benefits of early mobilization. And there was very low implementation of early mobilization in our Indian ICU. So these are some of the aspects which every listener could bear in mind, improve upon this. And more so, I would focus, even maybe in my ICU, our mobilization may not be as aggressive. So we should really put our more efforts in early mobilization, make patients walk. I think as you see, there are a lot of cycle ergometries being incorporated in Western ICUs. That is something in India we should start adopting, so that we make them mobilize. Even when they're not able to mobilize, at least they can do certain active physiotherapy exercises. All this is shown to reduce delirium. And we should have a high index of suspicion in any patient who is restless, whether he's developing delirium. And there should be a move towards moving away from benzodiazepine based sort of a sedation. So what about dexmedetomidine? Because this was a good study where, which is a meta-analysis where there is a shift in using towards dexmedetomidine more. So this was a meta-analysis of, as you see, 5 studies, and they showed this meta-analysis as favoring the usage of dexmedetomidine as compared to other sedatives. So I'm sure there are newer evidences that has evolved, and one could debate about this. So this was one study which came in 2016. So dexmedetomidine for the prevention of delirium in elderly after non-cardiac surgery, a randomized double-blind placebo-controlled trial. So here they used dexmedetomidine to prevent delirium. So this was a randomized controlled trial. They took patients aged more than 16 years, 1:1 randomization. Here they compared IV dexmedetomidine versus placebo. They used it as a preventive measure to prevent patients from developing delirium. They used dexmedetomidine at a dose of 0.1 micrograms per kg per hour up to 8 hours post-op. Primary endpoint was to see patients developing delirium in 7 days post-op. So they did this study from 17th August to 20th November 2013. And if you see the results, 700 patients, 350 in Dexmed group, 350 in placebo. So the delirium was 9% in Dexmed group as compared to 23% in the placebo, statistically significant. And the hypertensive episodes were significantly less in dexmedetomidine group as compared to placebo. Tachycardia rates were much lesser, 7% as compared to 14%. And hypotension, bradycardia, there was no difference. So this study overall is a hugely positive study where dexmedetomidine seemed to have a very favorable effect on the hemodynamic status also, and in alleviating and mitigating the delirium component. So that is the basis. So conclusions they made was patients more than 65 years who underwent non-cardiac surgery, prophylactic dexmedetomidine was shown to reduce delirium at 7 days and was found to be safe. So one has to adopt the usage of this ABCDEF sedation bundle. So this is an acronym. So A stands for awakening. Every day we lighten the patient, and B is putting them on spontaneous breathing trial or weaning process. And C is choice of sedation. As I said, analgesia first sedation is something that one should keep in mind. And D is every patient has in the ICU has to be monitored for delirium monitoring using CAM ICU score or ICDSC and appropriately manage the delirium. And E is early mobilization. So this is something which we need to emphasize. And F is mainly the counseling and communication with the patient and the family member. So ABCDEF is a reasonably easy acronym to keep in mind as to what are all the things that an intensivist during round should bear in mind that needs to be implemented in the patient to improve the outcomes. So the summary and take-home message. So the guidelines suggest the evidence-based strategy to sedation is easy to implement, and pain, sedation, and delirium, all these coexist in a patient, and all these have to be evaluated and appropriate measures to taken to alleviate this. And we have to use appropriate assessment tools and appropriate treatment plans for this. And there is a move towards analgesia first sedation. So our whole effort should be to alleviate pain followed by sedative attempts. And there is a move from benzodiazepine based sedation to non-benzodiazepines. As I said, non-benzodiazepine sedation with dexmedetomidine or propofol seems to be getting more emphasis. And most importantly, promote early patient mobilization in the ICU, and that has shown to significantly reduce the occurrence of delirium. So thank you, one and all.